Hello and welcome everyone. I see people are hopping into our webinar now. We'll give everyone just a couple of minutes and then we'll get started. Welcome, welcome. I see some familiar people there. Hey, Cindy, good to see you. I see Chaplain Joe as well. Good to see you as well. Dr. Neverson, hello, welcome. So we'll probably get started in about probably closer to 12:05, just to give people time to finish up their lunches so they can hop on here. And some of you may be multitasking. Some of you may be having your lunch while you're listening in. And Pamalia, I see your question there in the chat about presenters only being visible. Yes, only presenters will be visible for now. We may be able to open things up during the Q&A session, but we want to make sure that the presenters are visible to everyone. So you have a few more people who joined in. Welcome, everyone. We'll be getting started in a couple minutes here. Yes, yes. Good afternoon, Danisha. Thanks so much. Good to see you. Yes, and it is a happy Friday and happy MLK Day weekend for everyone. I hope you enjoy the extra day off. Right, just a couple more minutes here. If you're just joining us, good to see you. We'll get started shortly. And no worries, Mary, about your microphone not working. We'll actually be utilizing the chat function a lot during this webinar, so you'll be able to communicate that way. All right, it is 12:05, so we're going to go ahead and get started. Again, welcome everyone to our now, I believe this is our third webinar as part of our People Like Us campaign, which is an anti-stigma behavioral health campaign led by the VOA Hope Center and a number of community partners, one of which is representing us as a speaker today from the Denny House, Mark Harrison. And today's webinar is very timely. We're going to be focusing on health disparities and cultural competencies and how this impacts underserved populations and kind of explore some of the best practices and ways we can begin to kind of improve the way that we help individuals from these underserved communities access the support they need, both in the health and behavioral health space. So my name is Nicole Granger, and I'm the Executive Director of Fundraising and Development at Volunteers of America, Chesapeake and Carolinas. I'll kind of be helping to guide our webinar today. Now, our esteemed speakers for today, I'm super excited to introduce you to. We have Nicolette Smith-Bligen, who is a part of Volunteers of America, Chesapeake and Carolinas. She is our Vice President for DC programs and has over 25 years of experience in human services. And prior to working at VOACC, Nicolette was Executive Director of the Family Investment Administration, Maryland's statewide income assistance program with the Maryland Department of Human Services. And she has held executive leadership positions in both nonprofit and government sectors. And we are super excited because Nicolette also heads our Diversity, Equity, and Inclusion task force here at VOA. Also joining us as a speaker is Mark Harrison. Mark has been in the mental health and nonprofit field for over 15 years and has served in a number of key roles. And I mentioned the Denny House earlier. Mark actually serves as a board member there, and his true passion has been serving in the public space, focusing on the importance of mental health and wellness within Black and Brown communities. Mark is also an executive director of a local nonprofit that focuses on providing returning citizens the life skills training they need to reintegrate into society. So before we get started, we're going to take a little poll. We like to do this to kind of get to know our audience a little bit better and better understand what inspired you to join today's webinar. So Donna, if you wouldn't mind throwing that poll up on the screen, and we'll give everyone just a couple of minutes to answer. So the questions are, what inspired you to join today's webinar? And there are a few different options there. And the second question is, how did you learn about today's webinar? So go ahead and take a couple of seconds to fill that out. All right, so I think the majority of people have submitted that. So we can go ahead and take that down. And we'll go ahead and get started. I'm going to turn it over to Nicolette.
Good afternoon and happy Friday to everyone. I'm just going to add to what Nicole mentioned a little bit more about me. I am a social worker at by training, right? And one of the things that I think I'm most passionate about is the work that I've done throughout my career with underserved communities, from being a frontline social worker to working through administration and policy. So I'm really excited to talk about this topic. I think it's important, and I look forward to engaging with you on this. One of the things I would ask, and Nicole mentioned it earlier, is for you to utilize the chat. I'd love to know who I'm having a conversation with. So if you came to this presentation as a community member, please let us know that. If you came to this conversation from a person who works in the field, please let us know that as well. I think it's important for us to be able to engage well, to know who's who's in the room. So please utilize the chat for that. And if you have questions, please utilize the chat as well. And we will try to get to those questions as soon as we can within the presentation, but there will also be some time after the presentation to do that as well. So let's jump right in. Donna, can you, next slide, please. One of the things that I'd like to make sure that you leave this conversation with is an understanding of behavioral health disparities for specifically African American and Latino communities, leaving with a clear definition of what health and behavioral health disparities are, being able to have a definition for cultural competency and behavioral health. And lastly, leaving with some strategies and interventions for how we improve cultural competency for underserved populations. Next slide. I always like to start with numbers. Leading with numbers, I think, is really important. And we have a graph here, and the two areas that we're going to focus on today is the percentage of adults in need who have accessed mental health services in 2018. And as you can see, 8.7% of African American and Black Americans were in need to access mental health services, whereas their white counterparts, 18.6, were able to access the same mental health services. So clearly there's a difference there. The other percentage we'll look at is the percent of adults who were in need of receiving prescription medications. And there too, we see a difference. 6.2% of African and Black Americans received prescription medications, where their white counterparts, 15.3%, received prescription medications. So clearly there is a significant difference. And there are many reports out, there are many surveys out there. This is just one. I thought that it captured the disparity between Black and Brown communities and communities of color. This is one that the Center for American Progress put out, and they're really reliable in this area. So I wanted you to get a sense, but there are many reports out there that show differences. But what is primarily the same is that there is a disparity between communities of color and non-communities of color. Next slide, please. We also looked at our Hispanic and Latin American communities. We used the same question, the adults in need who access mental health services in 2018. And as you can see, there is a little, the rate is a bit higher with our Hispanic communities around those who actually were able to access mental health services than those in the African and Black communities, but there is still a difference. There is still a clear difference in both of these areas on those who were able to receive prescription medications in the Hispanic community, as well as those in the white community. And as you'll note as well, 4.6% of Hispanic adults reported serious psychological dis distress, and 40% more Hispanic females attempted suicide than white females. Next slide, please. So where are we? One of the things that I said that I think is extremely important is understanding what health disparity is, and what it's defined as. There's a report that came out from Healthy People, and that was a report sort of in the midst of COVID that came out through the federal government that I think really captured the definition of health disparity. And I think it's important enough for me to just read it to you. Health disparity is defined as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage, which may adversely affect groups of people who have systematically experienced greater obstacles of health based on their racial or ethnic group, their religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. A lot of times when we think of health disparity, we're only thinking around racial or ethnic as being the groups. But as you can see, there's so much more. And we have to take all of these other factors into consideration when we think about health disparity and how to reduce the gap. Next slide, please. Where we are. Behavioral health disparity. A difference in substance use or mental health outcomes linked to social, economic, and/or environmental disadvantage, which adversely affects a subpopulation or group. So when we look at our health disparity, it is obviously very similar to behavioral health disparity. All of those subgroups that I mentioned earlier are the same within the behavioral health disparity. Next slide. What contributes to health disparities? And I mentioned some of those previously: race or ethnicity, sex, sexual identity, age, disability, socioeconomic status, and geographic location all contribute to someone's ability to achieve good physical and mental health. And one thing that is really important to note is disparities are not a result of individual or group behavior, but of decades of systemic inequality in American economic, housing, and healthcare systems. And this one is really important. There's a lot of times where people believe that is something that they have done wrong, something that they didn't do, which has caused this disparity. And of course, that is not the case. The disparate impacts of the COVID-19 pandemic, ongoing incidents of police brutality, and recent rise in Asian hate crimes have brought health and healthcare disparities into sharper focus. However, health and healthcare disparities are not new. This is not something that has just happened and these communities are just facing. They have been documented for decades and reflect the long-standing structural and systemic inequities that are rooted really in racism and discrimination. Next slide, please. Where we'd like to be. Health equity is where we'd like to be. We define that as the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone's equality with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health and healthcare disparities. That's where we want to be. That's where we want all people to be at the highest level of their health. Next slide. I thought this was a good image of the difference between equality and equity. A lot of times we think, you know, we're equal, so everyone, so equity is equal as well. And if the resources are not there, you may be able to access, but the resources are not there to help you access it, then there really is not equity. The balance is not there. Are we providing the resources necessary, the supports that are necessary to have a equal playing field? And that's what this image demonstrates. Equity is where we want to be. Next slide, please. So cultural competence in behavioral health. We really want you to understand that culture, beliefs, sexual identity, values, race, and language all affect how behavioral health is perceived and how it's experienced. And I think that piece is really important, how people experience, because we can influence what treatments, coping mechanisms, and supports work best. Culture and identity must be included when we're having these conversations, when we're discussing behavioral health and its care. A person must feel comfortable and understood by the mental health professionals that they work with. To be in a therapeutic relationship, for it to be effective, they must feel understood and comfortable. When a mental health professional understands the role that cultural differences play in the diagnosis of a condition and incorporates that in cultural needs and differences into that person's care, it significantly improves outcomes. Temple University did a study on this, and they found what many others found as well, is that mental health care must be tailored to the individual, to their identity, to their culture, and to their experience. Next slide, please. So it's important to talk about what interventions and what strategies for improving cultural competence in the workforce for those who are working in the behavioral health field. How can they intervene? What strategies can they do? We need to make sure that there's education and increasing institutional awareness of the institutionalized bias and structural causes of poor health. beyond just the physical. We need to develop strategic partnerships with community-based organizations to hone in on the specific geographic populations. Who else out there is doing that work? Who can we partner with that is like mine and working with these geographic populations? We're establishing coalitions and partners with entities that advocate for policies or practices that promote racial equity. We're creating culturally tailored clinical services and communications. So how we are communicating are culturally sensitive, culturally aware. And we're integrating mental health in primary care and ensuring the availability of behavioral health services. Do folk know in Black and Brown communities that the services exist? And how are we helping to access them? Is there someone out in the field, going to churches, going to community events, talking to people, going where people are? These are some, not all, because there are other strategies out there, but these are some of the interventions and strategies that will improve cultural competency as we work within behavioral health and in the workforce. Next slide. So we thought it was really important that you at least have a background around cultural competence. Many of you probably come with the understanding of it, but some may not. We think it's important that you understand where we are as it relates to health disparities and where we want to be in terms of health equity. If you have any questions, please put them in the chat or please ask them. We're going to also move into personal story, personal testimony. Mark is going to share with us his story and his experience that I think will give a lot of context to some of the background information that was given in the slides.
Thank you, Nicolette. So as she mentioned, we would love to hear from you. This is kind of the midway point through the presentation. So if you have any specific questions about what was discussed just now, go ahead and put it in the chat and I will go ahead and share those with the speakers and we'll go from there. And just to kind of kick things off, I actually have a question for you, Nicolette. So Volunteers of America, Chesapeake and Carolinas, we're a health and human services nonprofit, and we've been working for some time in the behavioral health space. What are some of the ways that you feel we've been able to address issues around health disparity and cultural competency through some of our behavioral health programs?
I think the kind of outreach, the direct relationships that we have with the consumers who come for services has been extremely helpful. Sort of not looking at those consumers as a, someone just coming in for service, but looking them as someone who had a story, who had an experience, who comes for service with a background that we need to understand, appreciate, and be aware of. All of the experiences, the community experiences that come with that individual. And so we've been able to personalize the work that we've done in DC, and I think that that has been helpful. Building that trust, being able to, I think, infuse cultural competency in the assessments that we do, in the conversations that we have, I think, are important. Being present in the community has been important. Especially in DC, relationship is extremely important. People want to um, uh, understand that you will be there and not be here one day and gone the next. So I think that that's extremely important and something that we've tried to do and paying much more attention to doing as we move forward. But really being authentic, transparent, relationship oriented, and understanding uh, the individuals and consumers that come to us for service, I think is extremely important.
Awesome, thank you. I see a question here from Donna. Do we have language services for those who do not speak English in some of our behavioral health programs?
Actually do. We utilize our language access line to do a lot of that work. We continue to look for bilingual support, even more bilingual support to help us with that. But as most folk know, DC is extremely diverse beyond just Black and white. And so the need to have um, additional support with languages is extremely important. And we do utilize language services to help us with that and bilingual staff as well.
Wonderful. If there are any other questions out there, thanks, Linda. You're talking about our Hope Center in Maryland. We do use Language Line for our bilingual services. If anyone has any other questions or comments before we jump over to Mark Harrison for his testimony and a bit about his background and experience, go ahead and put them in the chat now. All right, not seeing any. We'll jump to Mark. Mark, go ahead and take it away.
Hey, good afternoon, everybody. What Nicola shared was actually very informative. I'm going to actually take a different approach to the disparities that we are having in our community and what's really been going on with me and why I decided to become a mental health advocate. Several years ago, I had a very good friend of mine who was going through some mental health issues. And this is before we kind of cliched the term mental health. You know, we were saying he's crazy, he's getting on our nerves, I really don't want to be bothered. You know, the typical stuff where we're kind of just putting it to the side. But I was the one up 3, 4 o'clock in the morning having these long, in-depth conversations with him. So one particular day, we were talking, it was 3 o'clock in the morning, and he asked me a question, like, why are you doing this? And my response was because I love you. For me saying I love you, it broke him down. I mean, broke him down to where I'm getting in the shower and I'm taking my cell phone with me, trying to get him off the ledge. So I said, all right, well, you know, just calm down. I'm getting dressed for work. I'll hit you up when I get to work. 11:42 on a Tuesday afternoon, and I can remember this date so well. I got a phone call from his girlfriend saying that he had shot himself in his daughter's bedroom. So that kind of sent me on a spiral, like, wow, like what is going on? Is there something that I could have done to make this brother feel better about himself? You know, and I'm putting the blame on myself, like, wow, I needed to do more. Is there more that I could have done? And here at this time, I wasn't even trained in mental health, so I didn't know. So when I had a chance to speak at his funeral, I would say 85% of the men in the room started crying. And I'm like, yo, there's definitely a problem. Then I just start speaking to guys about, yo, what's going on with mental health? Again, another one of my homeboys, and he's very prevalent in the media circuit, told me that he tried to kill himself 3 times. And I'm like, yo, what's really going on with our men? But while asking what's going on with our men, I had to look at myself. What about the issues that I was facing? You know, my friends call me the strong one. I'm being the strong one because really I am masking everything that's what's going on with me. And one of my boys gave it a term that means a lot to me. He called it emotional incarceration. That's what I've been doing the whole time. Taking my feelings and balling them up into one situation until we explode. So I just started talking about, how men, especially the men from the Black and Brown communities, we need to focus more on our mental health. While doing this, I wasn't focusing on mine. Again, I was still being that strong one. I couldn't let the world see me sweat. You know, I got to be that strong one to help everybody else out, but I wasn't helping myself out. Then going through all this, I ended up getting cancer. So my mental health went to a whole nother level. Again, I'm still trying to be strong. Nobody knew that, everybody knew I had cancer, but nobody knew that I was really suffering. So what I would do to mask the situation, if another strong point, and somebody says, Mark, can you describe yourself? And I always say, I am a recovering drug addict. That's how I dealt with my cancer, dealing with the treatments, how I was able to mask it. And when I say recovering drug addict, I mean, I was taking prescription opioids and then chasing it with vodka on a daily night so I can order to cope of really what was going on. The whole time I'm still speaking about mental health and why we should seek mental health therapy. But again, I wasn't going. I'm the strong one. Like, I don't need therapy. I'm going to work this situation out. It didn't work out until one dark day. I was at my house and one of my friends came over, and he's in law enforcement. And I'll say that, and he had his gun in my house. And, my house was a safe space. And I would say, bro, you don't even need to bring your gun in the house. But he did, but he put it down. Again, dark space. I'm sipping on vodka, not taking the pills, but sipping on, a substance. Put his gun down. He walked away to go to the bathroom. I got up to use the gun to actually commit suicide on myself. What stopped me from doing it? The phone rang. If that phone didn't ring, I probably would have shot myself in the head. And then he came out and said, yo, what's going on? And that's really how the journey for me going to go seek therapy really worked. However, I'll say, was therapy easy? No way possible. I had to learn what it is that I wanted out of therapy and who that I wanted. One thing I said when I do go through therapy, I didn't want a woman. I did not want anybody who did not look like me, and I wanted them to be age appropriate. And when I say age appropriate, I wanted somebody 40 and older, because in my opinion, if you're in your 30s, I'm going to talk circles around you. So I knew what I wanted for therapy. Once I got the therapist, I didn't know how hard it was going to be. It was extremely hard. And I tell people all the time, you have to go for yourself. And I start going for myself, and things start coming out, what some of my triggers were. Unbeknownst to me is my triggers were like many men. It was the trauma from my childhood that was never addressed as me being a kid that we take into our adulthood. The abandonment of my father, not having a real substantial relationship with my mother, the need to always wanted to be loved. That's where the part of me always being a strong person came in. And the therapist kind of took me through that, but it scared me. But going through that therapy kind of opened up a whole door up to where I am now, just having these conversations with people and having real life conversations. And yeah, a lot of people know I have a master's degree in clinical mental health. Now I tell people, so what? That was for me. I needed to do that to just really understand what these professors and everything else were really saying. But when I'm talking to people about therapy and therapists, I don't get into the book stuff because they don't want to hear that from me. They want to hear stories. And whatever it was, my stories became so good that the platform began to open up. NFL players started to reach out to me. And we were talking about their issues that they were struggling with. And a lot of people got into, you're talking to professional football players, professional basketball players. It wasn't about that. It was about their trauma that they were dealing with as well. And having people saying that, yeah, these are real people and that they are really, really, really struggling. But even doing that, I still had to maintain some type of level of me going to therapy because it works. The trauma that we face on a day-to-day basis, how do we deal with that? The stigma that's really associated with therapy, especially when it comes to the Black men, it's real. I tell men all the time, a true sense of masculinity is a man being vulnerable. When you can show your vulnerability, that is a keen sense of you being masculine. I don't get into, oh, what's the stigma? How are people going to feel about it? You know, my philosophy is everybody needs therapy in some shape or form. So it's how you going to do it. We live in a world where we tend to put everything on social media. We don't need to put that we're going to therapy on social media. Therapy is for you. I don't know why the world wants to put on Facebook, oh, I went to a therapy session last night, but then you're worried about how everybody's going to say something about you. Therapy is for you. It's not for the world. And that's what I tell people all the time. You know, it's about you dealing with those issues, concerns, and that trauma that has really impacted your life. And that's why I do what I do. Did I do this because I think it was really going to make a big impact? No, but it definitely has. And it actually has scared me with all the people who reach out to me and say, wow, brother, your story was something that I've been going through my whole time and I didn't know how to deal with it. And I'll give you another example. I was doing a show on WHUR and I was telling them about the gun situation. And that was actually the first time I had shared that situation. And a gentleman called in to the radio station and he just started crying and you can hear the distress in his voice. It got so bad that whatever my story was kind of resonated with him. He was ready to go out and commit suicide by cop because that's how much of a deep, dark depression that this brother was in. However, we were able to kind of talk him off that ledge, but he felt so much relief that I am not in this struggle alone and that there are other people out there who are going through the same thing. But I always say, you got to take that first step. You have to go seek help. And, you know, I've probably within the last 2 years, probably been through 6 or 7 different therapists because I had to know what was right for me and what it is that I wanted. And that's why I do what I do. You know, I'm not a guru. I just like sharing my story. But I love when I hear people saying, thank you for doing what you're doing. You really went out and it helped me. You helped my son. You know, you helped my husband. You know, when men come to me and say, yo, bro, I didn't know, and I'm going through the same thing. Can you help me find a therapist? You know, and I kind of take them through that process. But, you know, I tell people all the time, it's going to be hard. And I can remember when my therapist said to me, yo, let's take it back to the beginning. I'm like, yo, I don't want to go back there. I'm trying to talk about what's going on right now. Not realizing that the beginning is why I'm dealing with the situation that I am dealing with now, bringing it into my adulthood. But since I've been going down this journey of being this mental health advocate, it has been phenomenal. And I'm just here to just say, whoever is going through something or struggling, seek therapy, talk to somebody. It is never as bad as you think it is. In therapy, I would say God created a therapist for a person. Make sure you utilize it. Don't be like me and wait until you're 50 years of age and say, hey, I need therapy. You know, go now. It's never too late.
Thank you, Mark. Wow, that's so powerful. Just hearing your story and a lot of things I think resonate with me, our other panelists, and the audience around how can we make these behavioral health services relatable, you know, to people? How can we meet people where they are? Can you talk a little bit about even just kind of navigating the behavioral health system, what some of the barriers are for individuals in the community?
Yeah, that has been a struggle, and I'm not going to say everybody do what I did because I get a little bit radical. On my first therapist, he died unexpectedly, and to me he was the best. I was really able to open up with him, and after that it became a challenge because I was very specific on who I wanted and what I wanted as a therapist. And like I said, I've been through many. So I got these situations where somebody told me, well, you're a veteran. You know, therapy should come without any questions, comments, or concern. That's incorrect. I wanted a Black male therapist. A Black male therapist is what, 1% of the therapists that are out there. And then when you get there, they may be in their 30s or early 40s. That was not going to work for me, being a veteran or at all. I started working with an organization who ended up giving me a therapist, but the commonality was we only can see you in another 6 or 8 weeks. And I said, I can be dead in 6 minutes. That's unexcusable. We need to fix the system now. And, and I got that, I agree with you, I agree with you. And I say, no, I don't think you understand what I'm talking about. So I got frustrated. And I emailed the therapist back, but this time I put every news channel on the email. Unbeknownst to me, the next day I got a call, I had a therapist. But you shouldn't have to go through that type of extreme to get therapy. And a lot of people really don't have that type of resource. Even when my friends are saying, I need a therapist, I need help, and I'm doing the research for them. The lack of some of the therapists who aren't even calling them back, and I get it. There's not many out there, and the ones who are out there are being bombarded. But again, to me, that's no excuse. If people are to the point where they say they need help now. The other concern that I dealt with, and I think I shared this with you, was when a therapist asked a client who happens to be one of his friends, what kind of insurance does he have? And my response, and again, this is my personal response, I said, he's getting ready to jump off the bridge, Blue Cross Blue Shield. You need to help him right now. So again, I had to take drastic means. So me doing that allowed the therapist to actually call them, but we have to find a way that we can get therapists. We need to talk about it in schools. We need to make this something that college recruiters are talking about. We need more therapists. We do. We don't have a lot. They're talking about other things when kids are going into schools. So it is very, very hard. The whole cultural competence thing, it's important to me. I knew I wanted somebody who looked like me, who understood what it was to be a Black man. Even in school, when I was working on my degree, I am pleased to say that, and I'll say the school's name, that the University of Phoenix is now changing their curriculum, because I got into it with the dean. I said, this curriculum does not serve the population that I live. You're giving me tools and resources from 1972 on another race. I said, for me, my job is to get in my car and hope that I return safe. I said, you're not going through that anxiety. Nowhere in this curriculum are we even talking about that, or how somebody clutches their purse when they see somebody like me, or saying, hey, is this your car? I said, these are things that we're dealing with. This is why our anxiety is so high. So now the school is actually looking at changing the curriculum to make it more modern. So I feel kind of good about that, but it can be a challenge, but you cannot give up. I knew it was important to me, probably because I've lost several people because of suicide and lack of a good therapist. That's why I became an advocate, and I go so hard when a therapist are very lackadaisy or the resources are not there. I say, I will call you and leave 2 messages. If you don't call me back, I'm going to email you, and then we're going to have a problem, because people need help. And you really want these people to get help. So you have to take a different approach. And that's the approach that I took. Somebody said, I feel you.
And just to add to that, because I absolutely agree with you, Mark, I think from the organizational perspective, we have got to be creative in how we recruit a diverse body of clinicians. We've got to work with the colleges, as you mentioned, HBCUs. We've got to be creative in how we do it, because the answer that is unacceptable is that they're not out there,
Right.
because they are. It's a matter of how intentional we are, how targeted we are, because I do think it's important. We don't just need additional Black males. We need more Black women. We need more Asian. We need other communities of color to be out there, to be in this field, to be working with our communities. And we have to just be creative in how we recruit them.
Agreed.
There was a question earlier from an audience member. So when a young man, a young African male, perhaps is in need of help, where do they start? What would you recommend? And this is a question for both of you.
Well, I'll take part of it. Then I've had those situations, and it really depends. One African American young male, probably about 14, he was in distress, and his parents didn't see it. His parents reached out to me regarding his particular son, and his son was saying maybe they'll pay me attention if I'm not here. The good part about that, even though he said that, he was talking to his older sibling. So I said to the parent, at least he's talking to somebody. And because he's talking to somebody, that means he wants help. So it's your job to go out and get him the help that he needs, but also take that opportunity to bridge those conversations with your child. Go to a place that's neutral. Don't do it in the house. Do something that he likes to do, and just kind of gauge your way in there. And while you're doing that, somebody on your team, wife, should be looking for a therapist, but you have to keep the conversation engaged and encouraged, but also with, even with children, be it young men or young women, you have to look at behaviors and patterns. When behaviors and patterns start to change, you know that there's something definitely going on. So that's what I tell people all the time. You have to be engaged. Tell them to get off them games and everything else that you're doing, and sit down and encourage your children. Have these, hard but realistic conversations, because they need to happen, because our youth are dealing with so much right now. The cyberbullying, social media. Everybody wants to look like somebody on social media that's not even real, and parents have no clue what's going on, so they need to really be engaged. But I've had a couple of those conversations, and I had to do that.
And I think you also need to dispel the stereotypes. You need to set the stage for these kind of things, even outside of therapy. So these stereotypes that to cry somehow it's weak, to to ask for help somehow that's weak. You have to dispel those therapy to talk about your feelings somehow that's weak. So I think as parents, as community, we have to dispel those kinds of things and show strength in a different kind of way. Strength in asking for help. There's strength in that. There's strength in being able to show your feelings. There's strength in being able to communicate. So I think we as advocates of in community have to dispel some of those things and make it comfortable for youth, for African Americans, for people of color to say, okay, I can go out and get a therapist, because there's no weakness in that. There's strength in talking. There's strength in communicating. There's strength in showing my feelings.
It is.
And we have another question from the audience. What is the best way to encourage someone to go to therapy who needs it, but they are hesitant?
Well, the question I always ask is, how do you know that they need therapy? What has happened to make you say that this person needs therapy?
And they may, it's more of a hypothetical, if therapy is the route, but they are hesitant, how do you encourage them to seek the additional support that they need?
Well, for me, I was that person who was hesitant. But because I go to therapy now, I tell people, I go, and and I'm glad I'm going. So I kind of share my story and say, you know, if I can go, you can go. You know, and I kind of give it to them like that. And I kind of give them the benefits behind therapy. It gives you a chance to share your own personal thoughts where there's no judgment and you don't have to worry about judging you at all. You know, again, we tend to get in that situation where the stigma on therapy is because the world is going to shun you. The world doesn't even need to know that you're going. And I always tell people, remember, you're going for therapy for you. It's not like you're going to the mall to buy a pair of shoes and you want to tell everybody about it. You know, therapy is always about you and making you the better person. And that's what I always do. I kind of keep reiterating that. It's about you. It's about making you that better person.
There's a comment that came in the chat about life coaches and mentors, which I agree, with a reframe. I think that that life coach can be your minister, can be Big Mama who is down the block, could be a coach, a football coach, a basketball coach, it so it is really how that individual defines the important people in their lives. Um, and so although I do think there's a place for life coaches, there are a place for mentors, I would just add that we find those things in some of the most unexpected places, and not in the traditional sense of what we may think a life coach is, or a mentor it is. It really is letting that person define who those important people who can guide them sort of on life's journey is.
I see some comments being put there in the chat. All great ideas, peer-led support groups, also great. And that actually makes me think, Nicolette, we do use a peer-to-peer recovery model for some of our services. Can you speak a little bit about that and why just being able to have that lived experience is so important to therapy?
Absolutely. We do have a peer support recovery program, and what makes that so attractive to people is because they can relate. They can relate to the experience. They can relate to some of the challenges and the journeys that some of them have been on. And I think that that is so important for a relationship, to be able to connect, to be able to trust, is to know that I am the only one experiencing this. Somebody else experienced this too. Their story is similar to mine, and they have come out successfully on the other side of it. So maybe if I do some of the similar things that they have done to get through the journey, what worked for them perhaps can work for me, or maybe I can learn lessons from them to apply in my journey and in my life. So I absolutely think strongly about peer support, and how attractive that is in the therapeutic process, in the relationship process, and in building trust.
You know, one thing I thought of that I wanted to circle back to was the idea of stigma. Could either of you speak to even just community-based stigma that may be hindering people from seeking services from historically underrepresented communities? We touched on it a little bit, but what are some of the common things that may even just culturally be creating stigma within some of these communities?
when I grew up is what happens in this house stays in this house. um, which you don't understand the level of trauma that has on you when you hold all that in. Or another stigma that we hear based on communities, just pray about it, take it to God. You know, and we continue to say that to our children now, you know, what happens in this house stays in this house. And I totally 100%, because I have children, disagree with that. If my kids need to go seek help, my kids are going to go seek help. You know, I don't even know how we can get away from that. We just have to start now. You know, I guess with me starting with my kids, you know, teaching them that it's okay to go speak to somebody besides a parent. It is okay to express your feelings and emotions. One thing that we do to our boys is, and I have done it, and I had to be honest with myself, especially with a son, what are you crying for? Boys don't cry, man up. Not knowing that if he's in pain and he feels that he needs to cry, go ahead and get it out, because I don't know the pain that he's feeling right now. So I had to look at myself as a parent and say, hey, I got to step back and be like, he's having an emotion that I don't know right now, and him getting it out is crying. Go ahead and let him cry versus holding it in, and then later on it comes out in another way. So for me, the stigma within our communities was, first I had to take a step back and remember what was taught to me and make sure that I don't repeat that cycle within my own children.
And for me, I just go back to what I mentioned earlier about just the thought that somehow it is weak to go and ask for help or to receive help, receive services, that somehow that is not, that is weak, and you're not toughing it through, and um, uh, you're unable somehow to solve your own problems, and so you've got to go out to somebody else to solve them for you. Um, so I think those are some of the things, particularly in that the African American community, that makes folks hesitant. Um, I do agree with Mark. I think a a big one is, pray on it, and it'll be all right. That's all you have to do, is pray on it. And so we know, right? Prayer and right, prayer and so I think part of that is really reinforcing that.
Yes, well said. Are there any other questions in the audience? I'll give you a couple minutes in case there are before we kind of move towards the conclusion of our webinar. All right, seeing none, Donna, can you go ahead and pull up the final slide? Or the final survey? You can go ahead and pull that up. We'd love to get your feedback on today's webinar. We like to do these every month or so. So always looking to see how we're doing. So take a couple of seconds there to answer those couple of questions. I see there was some trouble answering the poll. Donna, can you double check that the poll is appearing properly for everyone? There we go. Thanks, Donna. So while you're doing that, we're going to pull up the final slide as well for our presentation. And I'm just going to share with you all a little bit about ways to stay engaged and in touch with our People Like Us campaign. Again, this is our anti-stigma campaign, and there are a number of ways that you all can get engaged to help encourage others to, one, seek the services that they need, and just promote general public awareness around health disparities in some of the populations we were discussing today. So we do have a Facebook group, and we will be sending out a copy of this PowerPoint in an email, so you'll have access to all the links and all the information. We hope you'll consider joining our Facebook group if you haven't already. That's where we post updates about our webinars and other things happening with the campaign. Now, there's also another unique way to help encourage people to support, seek the support that they need. We are looking for stories. So if you or someone you know is interested in sharing your story about stigma around health, something you've experienced that you think could serve as encouragement for others, please submit that to us. That is a huge part of this campaign. And as Mark mentioned earlier, sharing stories and being relatable to people is really important in this field. And if you or your organization are interested in co-hosting a webinar with us about a topic related to mental health, substance use in underrepresented communities, reach out to us. We'd love to partner with you sometime later this year. And another great way to stay in touch with us is to follow our website for the campaign, which is voa-plus.org. So definitely check that out. And there's a way for you to subscribe to our email marketing as well. So that concludes our webinar. I hope you all enjoyed the discussions, were moved and found it informative. And we want to just thank you for taking time out of your Friday, especially before a holiday weekend, for joining us. So thank you once again, and we hope you'll stay in touch.